Good evening, everybody. My name is Kirsty van Stormbroek, and welcome to the final Open Hand Therapy Initiative webinar of 2025. This webinar is brought to you in association with the University of the Witwatersrand in Johannesburg, South Africa, and the South African Society of Hand Therapists. For those who are joining us for the first time, the Open Hand Therapy Initiative was started because we believe that everybody should have access to hand injury care. We believe that everyone should have access to education, and that educational opportunities need to be driven by the needs experienced by patients and therapists, that learning and growth happens through collaboration, and that this needs to be a lifelong process. So you're welcome to find out more about us on our website, and we'll share some details of that later this evening. Also, just a reminder, the recordings of previous webinars are available on our YouTube channel and cover a variety of topics. So be sure to have a look at those if it meets your need. Today's webinar, we'll be talking about the proximal phalanx predicament, how to regain motion after an extra-articular fracture. And then we have two presenters tonight, and this will be followed by a time for questions and discussion. But that's enough of an introduction. I would like to now introduce our first speaker for the evening, which is Isabel Mischke. And it's the second time that Isabel is joining us as a presenter. She joined us last year in December and presented on flexor tendon injuries, and her recording has been the most viewed recording on our YouTube channel. So Isabel, thank you very much for joining us again. Isabel decided to go into hand therapy after she sustained a hand injury as an occupational therapy student, and her passion for this area of practice sort of developed from there. She graduated in 2001, after which she worked in London at King's College Hospital. And interestingly, part of her caseload there were soldiers returning from the war in Iraq. So a very interesting part of her caseload there. Isabel then returned to South Africa, where she currently lives. And 20 years ago, she opened a private practice, which continues to run in Pretoria. She has also experience in initiating and running an outreach hand therapy program in Uganda. And she's presented numerous hand therapy lectures and presentations, and she loves her family, running, cycling, and swimming. So Isabel, thank you. We look forward to what you'll share with us this evening. Over to you.
Thanks so much, Kirsty. Hello, everyone. It's such a privilege to be with you tonight. I'm going to just start sharing my screen. There we go. Perfect. So it's my privilege to discuss splinting and therapy for proximal phalanx fractures in the first 8 to 12 weeks with you tonight. Evanthia is going to follow up with when there are complications and they do become stiff. But we are going to focus on how do we treat and manage a proximal phalanx fracture in the first few weeks. Just 1 second. I just want to grab something. There we go. Perfect. All right, so after this session, my aim is to help you to have some learning outcomes. And the first one is to describe the types of proximal phalanx fractures, and then to know which ones are able to be treated conservatively and which ones do you need to refer for surgical management, and then also how do you treat them post-operatively. Then third, understand the anatomy and the biomechanics that play a role in the splint positioning. So how to choose your splint, discuss the benefits of early active motion on fracture healing and soft tissue, and then apply your therapeutic principles to prevent and or reduce the development of complications. So the types of proximal phalanx fractures is firstly, we've got short oblique and transverse. Now these two are usually able to be managed conservatively. And then we get long oblique or spiral flag fractures, and they mostly require surgical intervention. So conservative management indication would usually be a simple, closed, minimally displaced extra-articular long bone fracture with less than 2 millimeters of shortening and less than 10 degrees angulation with no to minimal rotation. So in 1998, there was a cadaver study, which has been cited numerous times after 1998 in various research studies, but where they proved on a cadaver finger that 1 millimeter of bone shortening of the proximal phalanx translates to 12 degrees of extension lag at the PRP joint due to the bone tendon discrepancy. This is quite a lot. So if you think about 2 millimeters of bone shortening, that will equate to 24 degrees of extension lag. So if you look at this picture, what happens in a proximal phalanx is that the interossi insert on the base of the proximal phalanx and pull the proximal fragment of that phalanx into flexion. And then the central slip of the extensor tendon pull the distal fragment into extension, and that results in angulation of the proximal phalanx with the apex on the volar side. So it basically buckles out like this. So then the proximal phalanx shortens, and this results in a bone tendon discrepancy because the slack cannot be taken up by a proximal pull of the EDC tendon due to the sagittal bands that only allow a certain amount of proximal pull. And this results in lag and extension at the PRP joint and eventually also shortening of the volar plates. So in understanding that anatomy, we would like to then introduce an extension block splint that was actually initially introduced by Burkhalter and Reyes. But most of the surgeons, when they refer to you, they will ask for a Burkhalter splint. That splint is an extension block splint. So it is a dorsal splint with your wrist in extension, MPs in 90 degrees flexion or as much flexion as you can get, and then your eyepiece in extension, 0 degrees. What that does, if you think about the biomechanics, it actually reduces that flexor pull by the interossi of the proximal fragment. So it doesn't pull them into flexion anymore because you actually neutralize that pull. And then it shifts the extensor tendon distally so that 2/3 of the proximal phalanx is actually dorsally embraced by the extensor mechanism. And that kind of pushes that distal fragment down and stabilizes the fracture. If you look at this, you'll see that dorsal extensor mechanism actually stabilizes that whole proximal phalanx over the top. So these are various versions over the years of the Burkhalter splints. Wrist in extension, MPs in 90 degrees, and then body straps or body taping with eyepiece in extension. In our practice, this is what it looks like. So we make forearm-based splint with MPs in as close as 90 degrees flexion as possible. Eyepiece in extension, so we make sure that that straps up the eyepiece nicely in 0 degrees extension, and we add body straps. But if we see that eyepiece don't go into extension very well, we sometimes do add a removable piece of splinting material that can support the IP joints in extension when they are at rest. So if you can see, we actually you can put a strap over the dorsum of the PIPs, or you can just add that section of removable splinting material into your strap that goes volarly over the fingers so that it extends the IP joints. And this prevents the complication of a PIP joint flexion contracture. So the extension block splint, as we said, stabilizes the fracture and it aligns the fracture while allowing full IP joint motion. And then the early motion, that's what this splint allows you to do, is to start with early mobilization. And this allows the extensor hood to glide across the fracture site, and that prevents adherence to the fracture site. And then flexion of the MP joints. Remember the lumbricals, the function of the lumbricals is MP flexion and IP extension when they activate. So when you put the MP joints in 90 degrees flexion and you encourage the patient to start mobilizing early, you actually put the lumbricals in the optimal biomechanical position to accomplish full IP joint extension, preventing that PIP joint flexion contracture. What it also does, early active motion, active finger flexion in this protected position provides appropriate forces that stimulate healing. The pumping effect reduces the edema. The gentle stretch of the controlled motion stimulates the bone healing, and the elasticity of the ligaments are maintained because your MPs are in flexion, so the collaterals don't get a chance to become stiff. And the glide of the extrinsic tendons, the extensor tendons, as well as the function of the intrinsics are supported in that position. Good. So sometimes in our practice, if the fracture is in the distal third of the proximal phalanx, so more towards the PRP joint instead of the MP joint, we exclude the wrist. So then we put the MPs in 90 degrees flexion, IPs in extension without the wrist. There was a study published in September 2025, just recently, where a Lucerne cast was put on trial. And this is what the Lucerne cast looked like. So it's basically also a hand-based splint with MPs in flexion, IPs in extension, early mobilization. And their functional results were comparable to surgical outcomes. However, their complication rate was much lower than with surgical outcome or post-operatively. And the patient-related outcome was better. So the patients were way more satisfied as well. So this is a patient that was referred in my practice on the 24th of October. As you can see, so she had proximal phalanx fractures of the middle ring and little fingers. And her little finger did have rotation on the finger, but the doctor preferred that we start with conservative management first. So she was sent for a CT scan. So this is what the CT looked like. If you look on the left, you'll see that is the fracture of the little finger, and then second to left is the ring and the middle finger. The middle finger only had a small chip fracture on the radial side. And then if you look at the right-hand side pictures, that's from the side. So you can see there the apex volar angulation of the little finger fracture and the ring finger fracture. So we if you look at that picture with the little finger, we started with body strapping with spacers to try and maintain the alignment between the ring and the little. But then, as you can see, the ring was also climbing over the middle finger. So we added a small spacer with luxo foam inside our body straps just to separate those fingers from each other and try to maintain their alignment while doing flexion. And then we placed her in a Burkhalter splint with IPs in extension. So on the 29th of October, she was followed up. She had improved flexion at the MPs and the PIPs, decreased rotation of the little finger, as you can see, and also the ring finger, and the splint was then adjusted for more flexion because initially with the first referral, the pain was too much. She did have a little bit of a PRP joint flexion contracture that was starting to develop in the ring finger, so we made the thermoplastic insert to support the IPs and extension inside the splint. Yesterday, I saw in the practice, she's now 2 weeks post-injury. The edema is reduced, pain under control. She's got a PRP and DRP flexion improved since the first consultation. She had composite finger flexion of up to 1 centimeter from the distal palmar crease, hip to palm measurement, decreased rotation in the little finger, normal PRP extension in the little and the middle, and only a little bit of stiffness of 10 degrees in the ring PRP. So I think you'll agree with me, post-operatively, this patient would have been much worse off because she would have had a lot of stiffness, hardware in her hand, adhesion formation. This is what she looked like on the 24th and now yesterday in terms of the swelling, in terms of the flexion on the right-hand side, and then below you can also see her composite flexion is basically 1 finger from the palm. And this is what her x-rays look like at the moment. So there's already fracture healing and a little bit of callus formation that's starting to take place. And she's extremely satisfied. She's so thankful that she didn't have to have an operation. So then our plan will be from 6 to 8 weeks to wean the splint and mobilize with body straps only. And if necessary, splint a ring finger and PIP extension at night. And then keep on working on active composite flexion and PIP extension during the day. At week 8 to 10, with any patient with a proximal phalanx fracture that you're treating conservatively, you can start weaning or removing the body straps. You can start with strengthening exercises. If necessary, you can continue with a night splint in PIP extension or a long lever extension splint, which I will discuss a little bit later at night if necessary. And then also Evanthia, who's going to present after me on complications, will discuss the relative motion splinting. But if you still have a PIP flexion contracture, you can also introduce relative motion splinting at this stage. So in summary, conservative management of proximal phalanx fractures generally heal with less stiffness and improved range of motion as compared to post-operative management. Just remember your anatomy with your splint positioning. That's your take home. So make sure that you know why your splint needs to be an MP flexion, IP extension. Focus on edema and pain management because your edema is going to contribute to your stiffness. If it's too painful for the patient to attain 90 degrees or get 90 degrees of MP flexion initially, just increase the flexion gradually so that after maybe a week, you are able to get more MP flexion and IP extension so that you can reduce that fracture well. And then in terms of stiffness, manage your edema early. Make sure that you get good extension of your IP joints so that you don't end up with a PIP joint flexion contracture or a lag. And early mobilization is very important. So don't be afraid, even if there are fractures that don't have any hardware in them, they didn't have surgery or RF stabilization, you can start mobilizing with body straps. In that splint, with body straps, it's completely safe to start mobilizing inside the splint. This actually improves the fracture healing, facilitates soft tissue glide and elasticity, and it helps to reduce the edema. So start early. Good. Then in terms of surgical management, surgical intervention is indicated when there's more than 2 millimeters of shortening of the proximal phalanx, more than 10 degrees of angulation, moderate to severe rotation, fracture displacement, or then the types of fractures that are long oblique or spiral fractures. So I've got 2 patients in my practice at the moment. The one had KY fixation, but as you can see at the very base of the phalanx, on the left-hand picture, you can actually see it. There was a small fragment that got ripped out, a Wilson fracture that was reduced with a screw as well. And then another patient that was reduced with plates and screws at reduction internal fixation on the 27th of July. So with these patients, we usually make a hand-based MP flexion splint because the fracture is already reduced, IP extension and body straps, and sometimes in our practice, depending on the PIP position when it comes out of the back slab, our splints are sometimes made volarly because you already have a fracture that is reduced. You don't have to reduce the fracture with the extension block splint, but you still want to maintain that collateral ligaments, elasticity, and also the distal glide of the tendon. Okay, so you can start from day 4 post-operatively, but usually we see these patients 1 week post-op. Then we start mobilizing. They mobilize 3 to 5 times per day to facilitate the tendon glide and prevent adhesions. That's your most important 2 complications to prevent post-operatively, is to make sure that the tendon glides and that it doesn't adhere to the scar or the hardware. Okay, so active flexion. Make sure that you first focus on MP flexion and then PIP and DIP flexion, so you can block the MP inflection and then allow the IPs to flex and extend. Especially also when you do PIP extension, make sure that you isolate that PIP extension by blocking the MP. Otherwise, if you can see, I also had a proximal phalanx fracture way back before I was a hand therapist, but your MP will go into hyperextension. So you need to block that MP joint. Okay, so active extension of a PIP and DIP, as I said, blocking the MP, and then splint the MP flexion, splint in MP flexion, IP extension to maintain the length of the collateral ligaments and increase the glide of the extensor mechanism over the fracture site. Once the wound is healed, so that's 10 to 14 days post-operatively, immediately start with scar management to prevent the adhesions. Scraping, rolling, and fascia tools you can start with to prevent adhesions, but it's still very sensitive for 2 weeks, so usually we start with those at 4 to 6 weeks post-operatively. 6 weeks post-ORA for KYs, you can remove the MP flexion IP extension splint and start mobilizing with body straps during the day. You can start active isolated PRP extension exercises during the day and continue with your scar management, scraping, rolling, fascia tools within the pain limit. So if the patient has hypersensitivity, just make sure that you don't increase that hypersensitivity. But obviously with touching the scar, doing massage, the hypersensitivity should actually decrease instead of increase. This patient specifically, the one in the picture, she was very hypersensitive, and but she was so compliant, and she just continued with everything I gave her, and the hypersensitivity is so much less. So at 6 weeks post-op, if the x-rays show fracture healing and there's no flexion, there is a flexion contracture at the PRP joint, then you need to make sure that you start putting stretch on that volar plate. So then you can put a static finger extension splint, and what we do in our practice is we add a small section that extends into the palm to increase the lever arm at night, and sometimes intermittently they wear it during the day from 6 to 8 weeks onwards. So what they do is they mobilize with body straps during the day so that we can improve the flexion of the MP joints and the PRP joints and composite flexion. But you will sometimes see that during the day, that PRP flexion contracture or lag, it's as if that finger starts drooping a little bit. So then we tell the patients to put the extension splint on for an hour or two just to boost the finger again. And then they take it off, they mobilize with the body straps, and then they wear the splint at night. I will show you that splint now. And then also we introduce relative motion splinting, but Evanthia will also focus on that. Good. So 6 weeks post-RF or KWIS, that's the first patient that you saw the x-rays from. She had good MP flexion. MP flexion was 80 degrees. But her PRP extension had a lag / contracture of 30 degrees. So that is the splint that we use in our practice with a little bit of a long lever arm. So as you can see, there's a small section that extends into the palm, and then we just put a strap around the hand to make sure that we stabilize that splint on the hand. Then the strap in the middle over the PRP joint, that can be adjusted. So the patient is in charge of that strap. So we always make it a little bit longer. And that strap kind of pulls the finger flat against the extension splint, but can be released to just allow the patient to not have a throbbing or painful finger at night when they have to sleep with it, so they can release that tension on that strap. Then at 8 weeks post RF or KWIS, we start removing the body straps during the day. We work on composite finger flexion, and usually at this stage, the patients struggle with DIP flexion because of that EDC, the terminal tendon that's quite tight, because it needs to glide past the scar and the fracture site, which now has hardware over. So there's a lot of layers that want to get stuck to each other. So we work on passive composite finger flexion by strapping the PRP and the DIP. So first the PRP towards the palm, and then later on you can strap the finger in a hook with the PRP and DIP, as you can see, and then also again strap the finger towards the palm. Then after that, we instruct the patients to do that for about 2 to 3 minutes in the morning when they get up, because then they had an extension splint on at night, so the finger is quite stiff. They heat up the finger, they strap the finger like this, just to get them going, and then we encourage them after that to do some active flexion exercises. We also introduce exercises against resistance with therapy, and make sure that you also focus on the intrinsics. So you need to do adduction with the therapy as well. And in our practice, we also pull the therapy towards the volar side of the hand, and then encourage the patients to maintain that extension, to activate PRP extension as well as the adduction of fingers. And then also obviously focus on the lumbricals, strengthening of the lumbricals, because they do MP flexion and IP extension. And then the DIP or distal phalanx we strengthen with a peg to just make sure that that last bit of FDP strength comes and helps to bend that finger into composite flexion. Okay. Then 8 weeks post RF or KWIS, we continue with scar management. Remember that scar only settles. It takes up to 6 months for the scar to settle. So we encourage and educate our patients to keep on with scar management and fascia release. We continue with night splinting up to 3 to 6 months if necessary, but we wean it gradually as the finger allows. So in summary, with post-operative management, you can expect more stiffness because of the scarring and because of the hardware inside. Obviously, the K-wires are removed, but if there's a plate and screw fixation, or there's a small screw like on the first x-rays, there is a scar and there's hardware, and you need to make sure that that tendon glides past that fracture site. So make sure that you focus on edema and pain management. But with stiffness, you need to make sure that you start early. Mobilize for joint mobility, tendon excursion, and the soft tissue elasticity, so the ligaments. And expect a PIP extension lag. You can expect that because of the adhesions, and then also obviously tightness of the volar plate. And then expect MP joint stiffness if the fracture is more towards the proximal side of the proximal phalanx. So then you need to make sure, and you need to know which one to prioritize. If your MP joint is very stiff, then you need to work more towards flexion. But if you've got a PIP extension lag and volar plate stiffness, say for instance, like my patient, she had MP joint flexion of 80 degrees, but she had a 30-degree PIP flexion contracture at the PIP joint. So then you focus on the extension, because they will always get the flexion back, but they will not necessarily get that extension back if you don't focus on that. And then during the day, you work towards getting that flexion. Scar management to prevent and reduce adhesion. So make sure that you manage that scar well. And then in terms of splinting, you will continue with a relative motion splint to reduce the extension lag or the PIP flexion contracture, whichever one you are working with. And then not splinting in extension to prevent or reduce the PIP flexion contracture. That's what we will continue with. So I know this is a lot of information overload and there's a lot of things to consider, but just take a deep breath, use your clinical reasoning. We've totally got this. And there's my reference. Thank you.
Thank you very much, Isabel, for a very clear outline of how to manage proximal phalanx fractures that are being treated conservatively and those that are being treated surgically, and just highlighting those key therapy goals, and so much there to help us as we clinically reason through these type of injuries. And now I'm going to call on Evanthia, our second speaker. Welcome, Evanthia. It's lovely to have you join us as well. Evanthia graduated from WITS in 2005 and then completed her Master's in Hand Therapy in 2010. She started her career working at a community level, so as a clinic therapist, and then moved over to a large academic hospital in Pretoria, South Africa. But for the last 14 years now, she has owned and co-owned a hand therapy practice. Evanthia has also taught and presented at numerous conferences. She's passionate about continued education and teaching, and also loves family, music, and running. Evanthia, thank you very much for teaching us a little bit more about dealing with complications of proximal phalanx fractures. Thanks so much.
Thank you, Kirsty, and thank you for having me. I'm going to just quickly share my screen. I'm going to be talking about proximal phalanx fractures and the complications. I think that any therapist working in hands who does see their fair share of proximal phalanx fractures will know that they are hardly ever straightforward, and more often than not they result in one or more complications that we need to manage. There are certain complications that as therapists we can control, and that there are others that we unfortunately cannot control, and those tend to have a significant influence on one's process, and they can include things like the complexity of a fracture, the number of injured fingers, how it's been managed, whether it's conservative or all the way through to an open reduction, what is the resultant effect on the soft tissue, and what is the timing to referral. With regards to fracture configuration, and I know that Isabel has spoken a little bit towards this, just two things that I want to highlight again are that if you do have an oblique fracture, you run the risk of a certain degree of angulation. And that means that when you move into flexion, your finger can potentially scissor into the adjacent finger. Most often than not, you may have what we call the volar apex angulation, and that can result in a degree of shortening of the proximal phalanx. And for every millimeter of shortening that you get in the proximal phalanx, you potentially will have up to a 12-degree extensor lag. Now, the extensor mechanism has an ability to compensate to a degree for this lag, but only at about a 4 or 5 degree compensation. So you will still have an extensor lag if you have at least a 1 millimeter shortening on your proximal phalanx. Further to this, the way a fracture is managed will influence the potential outcomes. The more invasive the management, the greater the effect on the soft tissue and the greater the risk of stiffness. So specifically with KY fixation, we want to understand that when those KYs were placed, did they pin the extensor mechanism and the intrinsics? And for how long are those wires in? And what is the effect of that? When you are dealing with an open reduction and internal fixation, we want to understand how did that surgeon access the proximal phalanx? Did he split the extensor mechanism? Did he bypass it? And was he able to preserve the periosteum, which is the barrier between the extensor mechanism and the bone, in order to limit the development of adhesions? So I've likened the referral of a complicated or late referral proximal phalanx fracture to being faced with a Rubik's Cube. Whether you know how to do it or not, there are many factors to consider when trying to get the different sides to line up. And you cannot only consider one element when you are working with a patient. You have to consider all the elements that are influencing that patient's mobility and try and treat all of those elements at the same time, or at least be mindful of them. So what are we thinking about when we're assessing a patient? So we are looking at PRP joint mobility and MCP joint mobility. We are trying to understand tendon excursion, both for the extensors and the flexors, and how that is influencing mobility. We are looking to understand scarring and the effect of scarring on the extensor or flexor tendon, and what is the overall movement pattern? Is it an extrinsic movement pattern or an intrinsic movement pattern? And how does that overall affect hand function? It's always important to understand patients' pain and edema and how that is influencing their process. So from a mobility point of view, I have grouped complications into 4 sections, and the first being a rotation deformity, the second being an extension deficit, flexion deficit, or both an extension and a flexion deficit. Now, it's quite a big topic, so I'm not going to speak too much about rotation, except to say that in the later stages of rehab, rotation is very difficult to treat, and it's very difficult to effect change at this point. It's something that needs to be assessed and treated in the early phases. If you do see a rotational deformity, you do want to inform your surgeon of it, and you want to apply a derotation force. So you want to understand the direction in which that finger is rotating and apply a force in the opposite direction and potentially attach it to an adjacent finger, as Isabel said. When we're looking at extension deficits, we have passive deficits and active deficits. And a passive deficit of extension at the PRP joint usually occurs because of shortening of volar structures, namely the volar plate. An active deficit occurs as a result of an insufficiency of the extensor mechanism and an inability of that mechanism to glide proximally in order to lift the finger, and it usually happens because of an adhesion. So the limitation of passive and active extension at the PIP joint often results in what we call an extrinsic pattern of movement. The patient overextends at the MCP joint in an attempt to get the finger straight. A PIP joint flexion deficit, again, can be either passive or active. When we look at deficits of flexion, we understand that it occurs because of a shortening of dorsal structures, like the dorsal capsule, as well as an inability of that extensor mechanism to glide distally, therefore allowing for flexion. What can also happen is that the intrinsic muscles can be tight, which could also limit flexion. From an active point of view, restrictions are related to adhesions of the FTP and the FDS. I think that these are often underplayed when dealing with proximal phalanx fractures, but it is something that I'm seeing more and more often, which speaks to the fact that patients need to move early on in order to prevent that adhesion. So in this slide, I've got a couple of videos, but in that first video, you can see that the patient has a fair amount of passive flexion, but he's unable to engage his FDP and his FDS in order to make use of that available range. In the video and the image on the right, the patient has a deficit of both passive range of motion and active range of motion. So he's not engaging his FDP and his FDS, but he also has a PIP joint contracture. What you do see there is that he is using an intrinsic pattern of movement, which makes him move at the MCP joint instead of the PIP or the DIP joint. So what are we looking to treat when we have this complicated proximal phalanx fracture and a PIP joint, really? But we want to restore mobility at the MCP and the PIP joint. We want to improve tendon excursion so that we can recover extensor and flexor function and both passive and active movement. We want to manage the scar to recover tendon excursion, and we want to restore the appropriate movement pattern, be it extrinsic or intrinsic, depending on the direction of movement. And we want to recover overall hand function. We need to manage the patient's pain and edema. So everything assessed, we need to actually treat now. I want to talk a little bit about pain, because we need to understand that pain is not only a physical barrier, but it is a psychological one. And it begins from the moment that patient goes to casualty. If a doctor treats that patient or looks at that patient and says to that patient that, number one, you've shattered your proximal phalanx or you've shattered your bone, the patient takes that, internalizes it, and it will affect their process going forward unless someone helps them to change that. And so we need to be mindful about how we speak to a patient, what we say to them, the words that we use, not to incite fear and not to put the patient in a place where they begin to catastrophize. We also need to understand that a patient's primary role, or a brain's primary role, is to protect us from pain. Okay, and it's to protect us from the experience of pain and the fear of pain. Okay, so when the brain anticipates pain, it's going to say, no, thank you, I don't want to move, and it's going to block movement. And that's going to affect your process all the way through, from the beginning all the way to the end. And so as therapists, it's our responsibility to instill trust in our patient, that we are not going to hurt them, that we have their best interests at heart. And that trust is built on communication and education and the way you handle the patient. So the patient needs to understand the difference between pain and stretch, and that we're not looking to elicit pain, but we are looking to elicit stretch. The patient needs to feel that you are not, you know what you are doing. So the way you handle the patient, even from a sensory point of view, makes a difference. We need to lower that protective mechanism. When we talk about mobilization of a scar, we need to understand that that scar is responsible in part for an adhesion, and so we need to break the adhesion. So although we're looking at the aesthetics of the scar as one element, actually mobilizing that scar such that we can allow mobility of the mechanism beneath that is very important. And in order to do that, we need to incorporate what we call frictional massage. And in the video, you can see that I'm mobilizing the soft tissue distally towards the nail, and after that I'm asking the patient to activate his extensor mechanism proximally, and in that way we're creating a shear force between the skin and the tendon in order to mobilize it. So when we talk about how we are going to recover range of motion, there are a couple of theories. And historically, what was thought is that you're going to first work on passive range of motion, and then after that, you're going to kind of look to recover active range of motion. But more recently, we've understood that active movement is a powerful tool in recovering passive range of motion. But I don't think that you have to subscribe to one or the other. I think you can use both simultaneously, or you can start with one and then progress to the other. And I think how you decide what principle you are going to follow is very much dependent on your assessment. And so there are a couple of questions that you want to ask. You want to ask, how much passive range do you have? And how rigid is it? In which direction is it? Is it an extension deficit or a flexion deficit? And how much active range do you have? And why is it restricted, and in which direction? So let us run through a couple of treatment options. What we do know about passive movement, before I begin, is that passive movement or elongation of soft tissue responds better to a lower force over a prolonged period of time. And that's something that we need to bear in mind through all our treatment modalities. So the simplest kind of form of treatment that you can kind of help a patient in order to recover mobility in terms of modalities is a static splint. In my practice, I tend to use static splinting when I have a degree of deficit less than 40 degrees of extension. And I use it when a patient has a soft end feel. So they have a limitation, but it's spongy, it's soft. You know that it will give. I hardly ever use static splints full time. I use them intermittently in the day, and I combine it with active movement. But I do tend to use it at night so that any gains that you've made in the day are maintained overnight, and that the patient isn't resting in a position of flexion, which is an unsafe position for a proximal phalanx or a PRP joint at least. So moving further along, if you have a greater deficit of, let's say, more than 45 degrees, or your PRP joint contracture is got a harder end feel, then serial casting is a good tool to use. And it really does subscribe to the principle of low load and prolonged stretch. So you take the patient that has a PRP joint flexion contracture and you apply either plaster of Paris casting, or this is Orphi-cast that is used in this slide, and you let the cast set in a position of as much extension as the finger will allow. And you send the patient on their merry way, and they stay in that position for a period of a week or so, and they come back to you, and all of that soft tissue has then elongated such that you can remove the POP cast and stretch it even further. So if you include the DIP joint in your cast, you get better leverage on your PIP joint. But if you exclude it, you are permitted then, or you allow the patient to mobilize their FDP, which might be a crucial thing for their process. I would say that serial casting is really good when you have a significant extension deficit, but it's not good when you have both an extension and a significant flexion deficit, because in this way, you're sending the patient off for a week in extension and you're not allowing them to flex. So you have to choose your patient wisely. And you have to have a plan for how you're going to maintain those gains. So once you've taken them out of a serial cast, you have to have a plan to say, okay, they're going to go into an intermittent extension splint or a dynamic splint, but you've got to try and have a plan to maintain that. So next we're going to move on to the principle of active redirection. And the actual term of active redirection was coined by Judy Colditz, and it's a very effective tool to recover mobility. And its premise is based on blocking the normal joint, which is more often than not the MCP joint, to a varying degree, so that the force of muscle power is directed towards the stiffer joint, which is the PRP joint. It includes treatments like Sims casting and or blocking splints, as well as relative motion splinting. And it's a very effective tool, again, depending on the type and degree of limitation. So we're going to talk a little bit about the options. The one option of active redirect is called relative motion splinting or exercises. And this principle asks that you place the injured finger in 15 degrees more extension or flexion relative to the adjacent finger. So you're blocking the proximal joint to a degree, not fully, and you're redirecting force of muscle action to the appropriate joint. What's nice about this is that it can be used as an exercise, but it can also be used in function when you are applying a relative motion splint. A nice way to test whether this is going to work is the pencil test. I tend to use a spoon, but you apply the spoon appropriately and you test whether the pattern of movement is improved with this as compared to without it. So when we're looking at a relative motion extension splint, you place the finger in 15 degrees more extension relative to the adjacent fingers. And what that does is that it allows for improved extrinsic flexor activation. So you use a relative motion extension splint when you're trying to recover flexion. And the splint limits intrinsic activation, so it limits MCP joint flexion. I would say that I use this splint when I do have some activation of flexor tendons, and my passive limitation must be soft. I would caution that it's not the best splint to use when you have a significant extension deficit, because it puts that MCP joint into overextension when you are extending. Relative motion flexion splints do the opposite. So you're placing the injured finger in 15 degrees less extension or more flexion than the adjacent finger. So this splint is going to limit overextension, and it places the injured or adhered extensor mechanism in a more tensioned pattern, and it improves the movement pattern by blocking extrinsic MCP joint extension and allowing for greater intrinsic activation. Its use is when you have a flexion contracture at the PRP joint. I would say that it mustn't be fixed and it mustn't be over 45 to 50 degrees, because then I think your force of muscle extension isn't going to be enough to gain the range in the PRP joint. And you must have a degree of extensor mechanism activation. If you have no extensor mechanism activation, then I think you might not win, especially if you have a PRP joint contracture as well. Again, I would caution that if you have a flexion deficit, it's not the best splint to use. And again, as I said, depending on the degree of extension deficit, there might be better options. So Sims casting, which is casting motion to mobilize stiffness, is a principle or technique that was developed again by Judy Colditz, and it incorporates the use of plaster of Paris, which places the hand in such a position that available active movement is redirected to achieving desired range. So it's similar to the relative motion, except that the MCP joint in this case is completely immobilized, so it doesn't allow a degree of movement. It's also different in that it is non-removable, and that I think is an important point, because every time that patient moves within the period that the cast is on, the forces are directed to the appropriate joint and the movement pattern is adjusted. I would say that this is a wonderful tool, and it's used when there is a greater degree of stiffness, both actively and passively. when you're using a Sims cast, you kind of think cheap as do I have to put an entire hand into a cast? And that's not necessarily the case. You can block just the one finger. You just have to get a little bit more creative in your plaster of Paris application. You can also make a blocking splint from thermoplastic material. But the idea is that you completely immobilize the proximal joint so that the force of action is moved towards the affected joint. Having a removable splint allows that the patient can also use their hand in function or wash. So there are benefits to having it be removable. But remember that the benefit of having it be on all the time is also one that is important and shouldn't be underestimated. Dynamic splinting is something that I really, really enjoy, and it is something that requires a certain level of skill, but I think that it is an important treatment modality to have and to potentially use with patients with complicated proximal phalanx fractures and complicated PIP joints. I really like it because it subscribes to both principles of low load, prolonged stretch, when you have applied the dynamic traction. I love that you can apply it in both directions. So if you have both an extension deficit and a flexion deficit, you can apply traction in either direction. I also like that if you remove that traction and you've blocked the MCP joint, that becomes a blocking splint. Which allows kind of for active redirect movement. So it's also removable, so a patient can use it for function. I think it's just challenging in that it is a cumbersome splint and it is quite complicated to make. So you do need a level of skill to make it, but I think its use is very important and beneficial in complicated cases. I've just shared a video of a patient who has an extension, a passive deficit, but also limited excursion of her FDP muscle. And so she uses her splint intermittently in the day, both from a passive mobilization with the traction and then activation of the appropriate tendons once the pulley system is removed. So I've created a little bit of a flow chart of how you can treat patients depending on their deficit. I'm going to kind of delve into it in my latest slide to break it up. But really what I've done is, let's say you have a passive extension, a deficit, and your deficit is getting progressively worse. That is the treatment that I would use is I would start, if it's a small deficit, I would start with active redirect. I would start with exercises. If the deficit is slightly more but softer, I would incorporate a static splint. And as the deficit is bigger, then I would look to serial casting or dynamic splint. And the same applies kind of going forward. If I've got active extension deficits, then I would look only towards exercises and relative motion splinting. With a passive flexion deficit, I would look towards potentially using dynamic splinting. I think that if you have a deficit of both directions, dynamic splinting or Sims casting is your way to go in addition to exercise. So I've broken it up a little bit more. If in my hands, if I have an extension deficit that is active, but I have full passive range of motion, I'm going to look to do intrinsic activation exercises and potentially incorporate relative motion splinting. If I have a soft in-field passive deficit, I will look to do intrinsic activation with relative motion splinting and incorporate a night splint. As soon as I have a firmer in-field, then I will look to include dynamic splinting and serial casting in addition to my intrinsic activation and active redirect exercises. When I have a flexion deficit, I will look to do active redirect exercises when I have full passive range of motion, but a limitation of active range. If I do have a soft in-field with limited active range, I will look to do passive mobilization and active redirect exercises. As soon as I have a hard in-field, dynamic splinting and Sims casting will be included in addition to my active exercises. I think it's important to remember that you are not restricted to one modality, and sometimes you need to use more than one principle at the same time to promote different treatment aims. So in this case, my patient had proximal phalanx fractures of 3 of his fingers. He had a stiffness at the MCP joints, and so I placed him in a Sims cast in order to improve MCP joint flexion and a pattern of movement. But he also had very poor excursion of his FTP and FDS, and so I brought in a spoon and I incorporated a relative motion exercises in that in order to kind of treat both difficulties at the same time. So there are some patients that, despite our best effort, will still require capsulotomy and a tenolysis. And the post-op management is based on the assessment, but overall the goal is to move the joints that were injured and glide the tendons using the correct movement pattern. Splinting can support movement patterns, but also maintain the gains made in the day. Isn't always necessary, so you have to kind of understand and make that decision based on the assessment. So this patient had proximal phalanx fractures of his middle ring and little fingers. In January of this year, he was managed operatively with RFs, and he was immobilized thereafter for a period of 6 weeks. His surgeon then sent him for a bit of physio, but he was so stiff and so adhered that after months and months of therapy, he came to one of our surgeons for a second opinion, and she kind of took him straight to theatre. She did capsulotomies and a tenolysis, and then referred him to us for therapy 4 days in. And after assessing the patient, I realized that this patient hadn't actually moved in 7 months, and putting him into any kind of a splint would just reinforce a pattern of non-use. And so we treated him purely with education and exercise on his first session. When I looked to improve extension, I educated him that it was really important to activate his intrinsics. And when you're looking to activate intrinsics, bring those fingers into adduction when you're extending the MCP joint and the PIP joint, and you will limit the overextension at that MCP joint and direct forces towards the PIP joint. It just improves the pattern of movement. When we looked to recover flexion, I hardly touched this patient. I kind of just said to him, we need to start using your hand. And I started with larger cylinders, and then we progressed our way to smaller cylinders. And he was literally gobsmacked at how much mobility he had and how little I had actually hurt him. That he had kind of just lowered that protective mechanism and gradually just gained movement in one session. So I would say that education and function are a crucial treatment principle that you need to kind of incorporate into every session that you have with a patient. And to that end, I found a study that investigated extension deficits and the use of orthoses or splints in these. And the conclusion was that although orthoses did result in a significant improvement in range, the improvement didn't necessarily correlate with the increased function which was perceived by the patient. So in order for a patient to know that he is getting better and to feel that he is getting better, he needs to use his hand. Movement is key and function is key. And I would say that that is a huge take-home message for this presentation. It's a very difficult thing to treat, even at the best of times. And I work with a team of therapists, and often I pick up the phone and phone my partner Roxanne, and I say to her, Rox, cheapers, I'm stuck. Can you help me? So if you have resources that you can reach out to, please do, because it is a challenge to treat. But I'm more than sure that any therapy that you could provide is better than no therapy. So yeah, thank you.
Evanthia, thank you so much for that very rich presentation with so many ideas, and for making your clinical reasoning very evident to us. We're very grateful for it. We are at 8:30 here in South Africa, so we don't really have time for questions, but I'm going to squeeze 2 in there. First one, you talked a little bit now about functional hand use and how important that is, but what instructions would you give to patients in the early phases and perhaps in the later phases about functional hand use?
So I think that in terms of functional hand use, pain, number one, needs to be a guide, especially in the early phases of treatment. But I think what's key is pointing out to patients what are abnormal patterns of movement, and what are more appropriate patterns of movement. And so, for instance, if a patient goes to pick something up and they pick it up in a completely contrived way, it's to kind of show them, try and pick that up with your other hand. See what it looks like to pick it up in a normal pattern of movement, and you need to try and reproduce that in your hand. Often patients will say, yes, I absolutely am using their hand, or I am using my finger. And then I'll ask them to pick something up and they didn't, And so it's a very subconscious process where patients are completely unaware that they are excluding or using their hands in a very contrived way. And I think if we can educate patients and make them aware of how they are using hands, or how they are using their hand, that will go a long way.
Thank you so much. That's very helpful. And perhaps in the last question, just some of the factors that you consider in your strengthening program with a patient when you start and how you progress that.
We usually start strengthening as soon as there's fracture healing, or the surgeon refers back and says, we've got an x-ray with good callus formation. But usually then we only at 6 weeks start weaning out of the splint and start active range of motion with body straps. So we will usually, in terms of strengthening, only start at 8 weeks. And then, as Evanthia also showed, we definitely need to work on strengthening the intrinsics with adduction, PIP extension, but not MP hyperextension, also strengthening the lumbricals, but then specifically also working for the tendon glide in terms of composite flexion. And then we also strengthen PIP active extension with the TheraBand, isolating the MP joint so that it doesn't go into hyperextension, but make sure that we do put some resistance on the PIP so that we can increase that glide of the EDC tendon as well as the activation of the extensor mechanism.
Isabel, thank you so much for squeezing a lot into answering that question. Thank you. And thank you, everybody, for joining our webinar this evening. As I mentioned, this is the last webinar for this year. If you have any questions, please feel free to contact us at info@openhandtherapy.org. And then just to reiterate, you'll receive a link to the Zoom recording by the end of this week. So some of you have asked whether that you could get a recording, and that will be sent through to you. Our next webinar, it feels crazy to say, but will be on the 3rd of February 2026. And it will be our first ethics special edition webinar, and we're going to be it'll be a slightly longer webinar, and we're going to look at the topic of hand injury care for all, understanding the need and being part of the solution. So really discussing ways that we can advocate for extending essential hand injury care services to populations that need it. So we hope that you can join us then, but we will keep you posted on social media and in our newsletter with more details on that webinar. To keep up to date, please do follow us on social media. And if you'd like to join our mailing list, please go ahead and scan this QR code. And once again, thank you very much for everyone who has joined us from across the globe. It has been lovely having you. And once again, thank you to our speakers who have generously given us their time and their expertise. We are deeply grateful. Have a good day and evening for those who are in South Africa, and take care. Good night.